We're going to ask Dr. Wesley to get us started and sort of share with us sort of where are we now, Dr. Wesley, when it comes to this COVID thing? Is it still here, in fact?
We are still here. Thank you, Dr. Watkins, for the opportunity to present this information. We are still here, and it's amazing. We've been dealing with this for almost 2 years now. If everyone can see, this is a slide which shows the incidence of COVID infections in the United States. I should state, to begin with, that in the United States, we've had almost more than 700,000 deaths. We've had 43 million cases of COVID since January of 2020 to this point. And what this slide shows 5 peaks. And I just wanted to kind of bring us to this point very quickly. If you looking at where the little orange dot is, that was back in May, April, when we first started to see a peak, and we had the issues in New York. And then the second peak, we are in the summer of last year, all the sports was closed, and we were wondering, when is this going to end? And then this really high peak here in the Christmas holiday season. Elections were getting ready to occur at that point, and as you can see, that peak is extremely high. That's peak number 3. There was another, and the election occurred about this point here. We started to develop vaccines, and as you can see, there's a precipitous decrease in the incidence of COVID in the population. But then this is what the peak I want us to really be aware of. The next peak, which started in July of this year, and it's back up again. And it's something that there's not been a lot of attention put to it, but that peak is higher than all the other peaks except one. So that is where we are right now. Now, why are we there? What's happened? I want to just go through this slide very quickly because it talks about that 5th peak that we're talking about. This slide, if you look at the bottom, are the dates from June the 26th, coming up to September the 25th of this year. And what this slide shows is the variance and the predominance or the prevalence of the variants, the COVID variants that are in our population. And if you look on the right-hand side of the screen, you can see that the alpha and the beta, those were the initial COVID variants that we initially saw. And Dr. Cheetah's going to talk more about this later, but those are all, if you look back at the slide, you'll see that those were still present, or at least the alpha variant was present in June. But it's pretty much, as you come to the end of the slide, you see that the final bar on the left-hand side is completely orange. And that orange, B1617.2, that is the Delta variant. That Delta variant has come and it has changed. It has changed the situation for us, and that's why we have developed this new peak, because of the occurrence of this Delta variant and its implications on our populations. We're going to talk about that more, but I want you to understand why we are where we are, and so we can develop strategies to remedy this.
So Dr. Wesley, what you're saying is that it is still here.
It is still here. It is still here. We can go back to the prior slide, and you can see that peak is extremely high, and that's why we're still dealing with what we're dealing with.
So, Dr. McIver, Dr. Lawson, initially when we start talking about COVID, we primarily talked about the elderly, those were sick, multiple comorbidities, and so forth. And we said that the pediatric population really wasn't affected so much. And if they were infected or involved, that it was not deadly, wasn't really serious. Has that changed at all as we look at new variants?
Yes. So I would say it is not avoiding children. Children are certainly getting COVID. Thankfully, we are not seeing them as ill as we see the adults becoming ill. So far, we have approximately 5.7 million childhood cases of COVID. And following kind of a similar pattern that Dr. Wesley just showed, we had our peak in the summertime, and then we had another peak around December. Up until about a couple weeks ago, children made up about 16% of all the COVID cases. But what we've noticed is in the past few weeks, the proportion of cases that are pediatric cases has increased to about 27%. It's difficult to say exactly why that is happening, but I think it is a combination of the effects of the adults that have been vaccinated not making up as many of the cases, and the fact that children have gone back to school. And we have noticed, and Dr. McIver and I at work have noticed that more children are coming in the past couple of weeks with COVID infections again. So yes, the children are susceptible to COVID, and we don't want anybody to get ill. Our numbers as far as the severity of illness with COVID is, if something can be reassuring in this situation, it is only up to about 2% of children that get COVID end up in the hospital. And when we look at all the hospitalizations for COVID, that's only about 4% of all the hospitalizations for COVID. And then when we talk about the very serious cases of COVID, the ones resulting in death, which is, of course, what has very much been promoted with the adult patients, is that, if you get COVID, it could very well be deadly. Less than 0.03% of children that get COVID have their case end in death. And then when you look at the deaths overall, it is a very small proportion of all the deaths overall. And so what we see is that children are still getting COVID. They're making up a higher proportion right now of the cases, but overall what we're seeing is children are still doing fairly well. The concern that we noticed, or we had several months into COVID, was this MISC, or the systemic inflammation presenting in children that actually didn't come until a few weeks after they had their infection. And we noticed that it would follow the peaks. When we looked at the national numbers, you would have a peak in cases, and then a few weeks later, you would have a peak in COVID cases, in MISC cases. We have not seen a peak of MISC cases with this most recent peak in COVID cases. However, when I spoke to the infectious disease specialist at Children's National, she said we are starting to have some MISC cases again. So it could be that we are now at the beginning of what is going to be an uptick in MISC cases.
Those MISC cases, is there a way to predict who would actually are susceptible to those?
That's what's frustrating as a provider, is that we really don't have a way of telling who is going to present with MIS-C. Quite honestly, a lot of the children that I was around in the emergency department that did develop MIS-C, they were never noted to have a COVID infection several weeks before. So they were asymptomatic with their COVID. And then when they presented, it was with the symptoms of MIS-C. So it was definitely something that pediatric emergency providers, pediatricians, and even general emergency providers needed to be aware of, that, children coming in with just fever and a negative COVID test, it could be that their COVID antibodies were positive and they were infected in the past. And so being very vigilant for the symptoms that could go along with MIS-C and having it on our radar is something to look for.
Now, we know that vaccines seem to have had a very significant and positive effect on the adult population. What about vaccinations when it comes to children?
Yes, that I'm sure is a question that many people have. So, like the COVID vaccine in adults, we went through a period where it was a trial period. And once they got to a certain number of cases, we had that emergency use authorization that people probably remember. And then it was recently approved by the FDA for older patients. Right now, both Pfizer and Moderna, but particularly we're going to speak on Pfizer, they have had an ongoing study in using the vaccine in children. And most recently, they have submitted data for children ages 5 years old to 11 years old, that has preliminarily had very reassuring results. And so they have promoted it and presented it to the FDA and the CDC to get that emergency use authorization. So similarly to adults, where we were able to get it with approval, but not official FDA approval, the emergency use authorization, we're hoping that we're expecting it in October or early November, that they will also offer this emergency use authorization for children 5 to 11. In the meantime, they're continuing to enroll children in the trials so that hopefully in a few months we'll be able to have it FDA approved for children 5 and older. And during all this time, they are also still doing studies on children as young as 6 months. And those will get enough numbers to have good data to present to the FDA going forward. But what they have shown is that with a smaller dose for children, because like most medications, children do not need as much as adults, they are showing a very good immune response to this vaccination. So our hope is that by the end of October, we'll be able to get our children vaccinated.
Fantastic. And with that vaccination, Dr. McIver, is that part of the prevention and helping getting our children back in schools? Or how are we with that?
Yeah, so I'm going to share a few slides, but part of our mitigation strategy is going to be vaccines in kids. And we are, the CDC is recommending right now vaccinations in kids ages 12 and up. And we're hoping to get, the ages approved, the younger ages approved. But I'll just go through some quick facts about COVID and children and adolescents. And some of this seems common sense, but I think it's important to really drill this into all of our heads, that children can be infected with COVID. They can get sick with COVID. They can spread the virus to others. It's important for us to remember that minorities are disproportionately affected by COVID. And even though severe illness due to COVID is very rare in young children, one of the biggest concerns is that children can spread it to the older adults who are more likely to have severe disease. So you have school-age children bringing COVID home to the grandparents, and then the grandparents are the ones who are at risk, to get sick and hospitalized and possibly die. In terms of returning to schools, the transmission rate, they've done a lot of studies to see if students are transmitting the virus to each other. And really, it depends on the local transmission rate. So if you're in a county where the transmission rates are high, then you will see a higher rate of transmission in the schools. The vaccine coverage, if teachers are vaccinated and the 12 and up students are vaccinated, then you'll see a lower transmission rate as well. The types of variants, like right now, the Delta variant is highly transmissible. And if you have mitigation measures in place, which I'm going to talk about, then you'll have a lower transmission rate in the schools. So right now for the fall 2021-22 school year, the CDC and the AAP have pushed for kids to return to school. We saw a lot of negative effects from the kids being home, doing virtual school emotionally, mental health wise. The isolation is very difficult for the kids and for the adults. And so some of the strategies that the CDC has recommended, which are a lot of strategies, are to promote vaccination, which you asked about, Dr. Watkins, masking, and the most important thing is consistent masking, which is a little tricky with children. They tend to take their mask off or wear it below their nose, but it's consistent masking and wearing it correctly. Physical distancing, that has changed. Initially, they recommended 6 feet apart, and now they're saying 3 feet is sufficient. Screening is something that they're starting to push in the schools. Improve ventilation, and as much as the kids can get outdoors for lunch or for PE, to let them get outside. Hand washing, of course, we're promoting respiratory etiquette, which is, reminding the children and the teachers to cover their mouths when they sneeze. Also limiting the class sizes, cohorting the students, and really pushing the message, if you're sick, stay home and get tested. Do not send your kid. Back in the day, many parents would send their kids to school with a little fever, give them some Tylenol on the way to school. If your child is sick, keep them home and get them tested. And then, of course, routine cleaning. When it comes to the mask fit, a lot of parents have questions about how do they wear the mask and what kind of mask should our children wear. The key is that the mask should fit snugly over the nose, the mouth, and the chin. And if you can find a mask for your child that has the nose wire so that you have a good snugly fit, that's helpful as well. If you're wearing a cloth mask, that should go over the disposable mask for a nice snug fit. And if the cloth mask, also make sure that there are multiple layers on it. And they're recommending not to wear 2 disposable masks. You will see some people putting 2. Really, what they recommend from the CDC, if you're wearing like a surgical mask, over it, you can put a cloth mask, and that gives you the best filtration. I think you're on mute, Dr. Watkins.
That's not good, is it? So in this population, these precautions seem very, very practical, but do they actually work with this age group?
They've done a number of studies here in the US and in multiple countries of Italy, Israel, the UK, and they have shown that masks work as long as you wear them properly, and all of these mitigation strategies, they work.
Yeah, I guess my question is, with the actually wearing them, doing it, how successful have we been in actually getting our children to follow the rules?
I think it varies. I think some kids are very good and comfortable at this point with wearing masks. I have friends who say their kids refuse. They take it off. They don't like it. And I think that is a challenge with kids. They have said, the CDC has said less than 2 years old, they're not recommending the mask. I think for an 18-month-old or a toddler, it's very difficult to get them to keep a mask on. But it is a challenge for some families. Yeah.
So we found that the monoclonal antibodies have been very effective in if we catch the infection, say in the first 8 days or so in adults. What is the situation with monoclonal antibodies or things like that for children? Okay,
I will touch on that. I'm going to share my screen again. So the FDA has given emergency use authorization for outpatient treatment for COVID with the monoclonal antibodies for children. And so this is for outpatient treatment. These are children with a mild to moderate case of COVID. You're not planning to hospitalize them. They're not requiring oxygen. The hope is that by using the monoclonal antibody, you can prevent them from getting severe COVID and being hospitalized. The criteria right now are they have to be greater than 12 years old. They have to be, well, it's 12 or older. They have to be 40 kilograms, which is 88 pounds or more. And they have to have a high risk for progression to severe COVID-19, including hospitalization or death. So these are kids that look okay. You would send them home, but you're concerned that they have asthma or they have some respiratory illness or some comorbidity that may push them over where they would be hospitalized. So for these children, we are using the monoclonal antibody. We actually are using it at Children's right now, and we've had to change our protocol based on the variant and the effectiveness of, because there are multiple monoclonal antibodies out right now. And like you said, in adults, the earlier you treat, the better. So we have to use it within 10 days of onset of symptoms. And it's hard to even pronounce the names, but I'm putting them up there right now at Children's National. We're using the casirivimab and imdevimab combination, and it's called Region Cove. So yes, we are using it in children, and this is under the emergency use authorization from the FDA.
Another population that we're concerned about are ladies when they're pregnant. Dr. Woods, tell us, what is the risk for COVID in women who are pregnant?
Hi, first of all, thanks, Dr. Watkins, for inviting me to this discussion. I think it's really important for us to remind people that COVID is still an issue, and we need to definitely be mindful of it and protect ourselves from it. And as an OBGYN, you're right. We've actually had, I've had a lot of questions about COVID and pregnancy. And, you know, the risk of getting COVID is about the same with the general population. But what we're seeing is that because pregnant women, their immune system is a little bit more compromised, that when they actually have COVID, they're more likely to have moderate or severe symptoms of COVID that require more intense treatment. So we're seeing more pregnant patients that are having to go into the hospital and ICU, and unfortunately, a lot of them are having to have help breathing, either with oxygen or even on the breathing machine. So we really recommend, I know when I'm talking to patients that are pregnant or people that are pregnant, to do all of the precautions that they can to prevent getting COVID in pregnancy.
So is one of those things vaccinations?
Absolutely. And, you know, it's interesting because there's so many people that are concerned about vaccinations for different reasons, and definitely in the pregnant population. And I completely understand the concern. You never want to do anything that could hurt yourself, but definitely not your unborn child. And, you know, we're right now in a place where we've been observing quite a few patients or quite a few people that have received the vaccine since the vaccine has been available, including people who were in the trials that were pregnant, they were healthcare workers, and watching the overall outcome of their pregnancy when they're vaccinated. And right now, they're not seeing any significant complications associated with the vaccine and pregnancy. So yes, currently that is a recommendation. If you're pregnant, to definitely consider the vaccine. You know, anytime, and I know a lot of people are just like, well, you know, the risk and benefits. Anytime you look at the risk versus the benefits of anything, then you have to make sure that the benefits outweigh the risk. And, you know, are there side effects to COVID? Absolutely. Are there side effects to the vaccine? Absolutely. But the side effects to having COVID in pregnancy are a lot more significant. And that's why one of the recommendations, of course, is the vaccine. And the precautions for transmission, wearing your mask constantly when you're around people less than 6 feet. If you can do physical distancing, of course, and hand hygiene, and all of the other precautions that are recommended to the general population. It would apply to pregnant women as well.
Now, there's been a lot of things floating around in our community that this vaccine can change the DNA, can make a person sterile, all kinds of things that really are scaring a lot of women. I get people calling me, and I mean, they're hysterical. You have to write a letter so I don't have to take this vaccine. What does the data show about that?
Yeah. So, it's interesting that you said this about data. And I was just having a conversation with someone this morning about that. We have to remember that although the coronavirus has been around for a very long time, specifically the COVID virus has not been around that long, COVID-19. So remember, any data that we have is going to be short-lived. It's just basically from last year. And the data that we have around pregnant women is just observational data. But that being said, they have not seen any changes for those who received the vaccine during the pregnancy as, changing their, having issues with pregnancy, or for those who received the vaccine prior to getting pregnant. There have been women who have gotten pregnant after receiving the vaccine, and there has been no changes in the risk of miscarriage or early complications like early loss. They haven't seen any changes. Now, I understand why there's a pause, because at one point earlier this year, women were noticing that there were changes in their monthly cycle, and also noticing that there were changes in some of their mammograms. Anytime that women, you see women introduce something new to the body, there could potentially be changes in the cycle, but not anything that would necessarily affect their fertility. And as far as like mammograms, since I brought it up already, what we're saying is you don't need to necessarily delay your mammogram, especially if you're high risk. And you need to have a screening or a diagnostic test. But make sure you let your doctor or the radiologist know that you received the COVID vaccine if it's within 4 to 6 weeks of your mammogram, because they have seen some irregularities with mammograms within that time period of the COVID vaccine.
Fantastic. This is a lot of very good information, and I know I'm enjoying it. I hope our listening audience is also enjoying it. Now, Dr. Cheetah, Dr. Wesley, this whole issue of vaccinations and now boosters. I mean, where is this thing going to end? What's the situation? Would you say there?
Well, Dr. Watkins, first, thank you for inviting me to be a member of this august group. I think the way you have arranged this program in presenting information overall on the virus, its impact on our citizenry, as well as the pediatric population, and just a few moments ago, the effect on women, is exactly the sequence and order of information that needs to be presented. When it comes to the data that we all have to depend upon, and it's important, I want to emphasize the fact that there are lots of stories that are circulating, there's lots of rumor that circulates. What I'm going to give you is based on data, because that's the arena that I have worked in. And when we look at the coronaviruses as a group, we know by history, and I'll just allude to the fact that I've just completed 10 years of oversight of the United States Navy's medical laboratories based worldwide, 8 medical laboratories in places such as Cairo, Egypt, and Jakarta, Indonesia, Hanoi, Vietnam, and Lima, Peru. It's important to note that the Navy has been surveilling coronaviruses for over 20 years. In fact, 3 of our laboratories are in the Far East. They're in Eastern Asia for the purpose of monitoring coronaviruses, because you can imagine what would happen if coronaviruses got loose on board our ships. Well, we know from the study that has taken place within the Navy for 20 years now, studying various coronaviruses, that these viruses mutate very, very rapidly. They change. They present themselves, and then if they take up residence in a population of people faster than many other viruses, they will mutate to a different form. And so the whole issue of vaccines is important because we use the vaccine to treat the predominant variant that is infecting individuals and causing disease at the given moment. But coronaviruses mutate. And so you have to be prepared to later on take a different form of a vaccine, or in the case of the vaccines that have been prepared thus far, we know that after about 6 months, the antibody titers in individuals decline and decline fairly rapidly after 6 months, with Delta variant showing us how lethal it can be and how contagious it is. It's extremely important for individuals who are in the target groups for getting boosters to get that booster, especially after 6 months. As I alluded to, in the Navy, we studied these viruses in the Far East and found that the viruses often mimic other things that take place in the environment, but the predominant pathology that they cause is inflammation. What's taking place in individuals as they develop this lung disease and difficulty breathing is that the lungs become inflamed because the virus targets the vital organs. The virus, by the way, doesn't only target the lungs, it targets the heart, it targets the brain, it targets the liver, it targets the kidneys. So a lot of our attention has been based on, oh, did someone have coronavirus? Did they die or did they not die? That's an acute effect of the virus, but chronic effects of the virus, ongoing inflammation in these other organs is something that lingers on for months and months. It has already been alluded to in the pediatric population about the inflammation that seems to occur even after the infection is gone. We're also seeing, as an endocrinologist, very important to me, that in children, the incidence of type 1 diabetes in children who have been infected with coronavirus is almost twice as what it would be in the normal population, primarily because what appears to be inflammation of the pancreas that's taking place. We're studying that very closely. So the vaccines are important. The boosters are going to be important for anyone who is in an age group where the booster recommendations have come forward.
So the monoclonal antibodies,
Yes.
have they really been successful? I've used them with several of my patients and got good results with each of them. What about the general population? Is this something just that I'm seeing with the few select patients that I've used, or are they really effective?
The monoclonal antibodies seem to be reasonably effective when given to the selected group of individuals for whom an indication has been provided. That is, they have to be given relatively early on in the course of the disorder, but they also need to be given to individuals who we recognize are going to have a difficult time on their own defeating the virus unless they have some early assistance. Those who seem to be making a rapid decline in their ability to maintain respiratory function, and others, the monoclonal antibodies seem to be effective, but they're not for everyone, and they certainly don't prevent the infection in the first place. So you can't go out and take monoclonal antibodies as an antidote so that you don't get infected. Beyond that, because we are now seeing with the Delta variant and other variants that are going to be coming along, the monoclonal antibodies are only being produced against and administered to fight against the original virus. So they seem to be a little less effective against the Delta variant. And as the other variants come down the pipe, such as Lambda or perhaps Mu, we know that the monoclonal antibodies we have now may very well not be effective at all. As I'll also add in, our vaccines may not be effective.
So that would be even more reason to have a booster that would be able to deal with some of these other variants. Because I hear that they're in addition to the Delta, the Lambda you mentioned, we have others that are coming down that are even more lethal than they. So we need to really go back to practicing social distancing, wearing a mask, doing all the things that we can do to prevent people from getting infected.
Yes, that's entirely correct. And I'll just end by stating that vaccines themselves are not antiseptics. Vaccines don't make you clean so that you cannot get the virus. A person who has been vaccinated can become infected with the COVID and can pass it to other people without showing any symptoms whatsoever. The vaccine protects you from becoming ill. And you may not even show that you have the virus, but if you have come into contact with someone else who does have the virus, even though you are vaccinated, you can carry that live virus with you for several days and pass it on. So masking, social distancing, using all of the other criteria that have been recommended has been shown on the basis of data, and the data speaks to be very, very important. You can't put down your mask and you can't stop washing your hands and social distancing just because you've been vaccinated.
Now, you know that I'm in the area of preventive medicine, so or more holistic medicine. So I'm very interested in the impact on diet and other nutritional things that you can do to boost your immune system, protect yourself. There was a very interesting study that came out a few months ago. At least that's when I saw it, looking at the impact of diet and on the prevention of COVID. Can you, either you or Dr. Wesley, say anything about that?
Well,
diet and other means.
Right.
So.
I've been talking for a bit. I think Dr. Wesley should have a chance here to weigh in, and I'll come back on if there is any additional information that needs to be presented.
Thank you, Dr. Cheetah. I thought that was a wonderful presentation of kind of where we are now. There was something I did want to mention before we move on from the monoclonal antibodies. There was one other thing I wanted to state. Some of you may know I'm an emergency physician. I've been practicing at this for 30 years, and I've worked all over this Mid-Eastern states. And I received a letter from the Department of Health, Maryland, dated September 27, talking about monoclonal antibodies. And I just want to read part of it to in your hearing. It says the Maryland Department of Health strongly recommends monoclonal antibodies when clinically indicated. And monoclonal antibodies are a critical tool in the battle against COVID-19, are effective against variants. They are effective against variants, including the highly contagious Delta variant. Currently, the Food and Drug Administration has authorized its use, and they talk about that. I want to go further. Monoclonal antibodies have been approved for the treatment of mild to moderate COVID-19 infections in individuals who are at high risk for progressing or severe disease, or, and this is very important, as a post-exposure prophylaxis for unvaccinated or immunocompromised individuals who are at high risk for progression to severe COVID-19. So that's a new one. That was a new one that I saw, and I wanted to make sure that we were aware of it. I also think in our population, individuals don't know, okay, I tested positive. Is there anything I can do? Well, if you don't know about this monoclonal antibody, you won't advocate for it. So I think it's very important that our community knows that this is something that this is an option. And the question is, who are considered high-risk individuals? And I'm just going to go through this list. Body mass index of greater than 35. So you can find a body mass index online, but it's something that, that's an indication in and of itself. Chronic kidney disease, diabetes, immunocompromised condition. So, individuals who are HIV or who may be immunocompromised secondary to chemotherapy. Also, people who are age greater than 65 years of age. Also, people who are greater than 55 years of age but have cardiovascular disease or hypertension or COPD. So there are a number of individuals who may fit the criteria for getting this treatment. And as Dr. McIver mentioned, this is something that's not, you don't have to be admitted to the hospital for it. There are infusion centers all over the area. One of them is at Washington Adventist Hospital. And they can provide this if you let your primary physician know, or even, call there and see if they can find one for you. But this is something that, I want to make sure that, we advocate, we have the knowledge to advocate for ourselves. So that's number one. Number two, you asked about dietary prevention. And, one of the things that we need to realize is that, okay, so you've tested positive, or even if you've not tested positive, if it's just, in the environment that we're living in, the thing that helps us fight this virus is our immune system. So our immune system being as primed as possible allows us to ward this off possibly. That means getting plenty of rest. That means eating a diet, and you talked about the diet, eating fresh and unprocessed foods as much as possible, drinking plenty of water, moderate amounts of fat and oil, limiting salt and sugar, and it actually says this, avoiding eating out. Sometimes we're better off making it ourselves because we don't know what they put in when you eat out. So those are some of the things, as well as getting, just making whatever we can do to be as primed and as rested and as healthy as possible with regards to our immune system.
We hear a lot about the importance of vitamin D, vitamin C, NAC, different things to help protect you. And I believe in those things. I have something I give to all of my patients to recommend using supplements to boost the immune system. But I had a situation not long ago when one of my very good friends went to a conference, his vitamin D level, and there's been a number of studies showing the importance of vitamin D and boosting the immune system. His vitamin D level was over twice the upper limits of normal. And he came down with a severe case of COVID, having not been vaccinated. So, would you recommend that that people get vaccinated, even if they are following dietary and supplementary guidelines? In interview.
So I'll start off on providing an answer, because I do recognize that vitamin D is a critical vitamin for normal function of the immune system. Many people don't recognize that. People have focused on vitamin C perhaps and other nutrients, but vitamin D is critical to normal function of the immune system. That said, vitamin D alone is not going to be capable of protecting an individual completely from the ravages of the coronavirus. So I definitely would recommend taking vitamin D, but also being vaccinated. We have two critical interventions that we know work. The data shows that they work. Dr. Fauci and I served on multiple committees together when I was still with Department of Defense. And he is straight down the path in terms of telling you that you have to use the data. And the data tells us that vaccination and masking work. Vaccination and masking work. You may be able to cut down on the likelihood that you will come down with a severe infection with COVID, severe enough to take your life. But remember what I told you about the chronic complications. You can survive even asymptomatic COVID if your immune system is capable of protecting you, but the chronic complications, that inflammation stays with you for months and it destroys organs, it destroys tissues. You don't want to get infected in the first place if you can avoid it.
Yeah, you're describing the long haulers, and I did a radio show on that, and it's amazing because early on when it was first noted, at least the first time I noted it was in young athletes that were asymptomatic, didn't even know that they had contracted COVID, and yet their performance started decreasing. And when they were evaluated, they found out they had a myocarditis, inflammation of the heart that it's secondary to the COVID virus. And so this is something that's very, very important. But also, people often throw up the fact that, and there have been recently the Supreme Court justice got infected and he was vaccinated, and others, one of the senators got infected who was vaccinated. So vaccinations doesn't keep you from getting infected, correct?
Correct.
So we don't need to get vaccinated then, since it's not going to keep you from getting infected.
No, it doesn't keep you, it doesn't give you a 100% protection, but it certainly decreases the likelihood that you will have symptomatic infection, and it significantly decreases the likelihood that you would die if you are infected. That's a big difference. Remember, both acute complications, respiratory failure, death, and the chronic complications. So don't say, oh, well, it's not going to keep me from getting infected 100%, therefore I'm just going to rely on something else. No, everything helps.
Very good, very good.
Dr. Watkins, if I could just, I wanted to chime in here. Dr. Cheetah talked about presenting data, and I went to the CDC website, and there is just a tremendous amount of information, current information, that is available on the CDC website. And I just want to present this to our audience because I want to make sure everyone knows, and this touches on the vaccine and just the data, okay? So this is a slide which shows the percentage of patients in PG County who are positive, okay? The percentage when they're tested, they're positive, okay? And it also tells the percentage of the population that's fully vaccinated. And you can see the eligible population fully vaccinated is 71%. The positivity rate is 4.53%. That's in PG County. In Montgomery County, the percentage positivity is 2.21%. You can see that their population that's fully vaccinated is higher at 89.2%. Okay, so a higher level of vaccination, and for some reason they have a lower level of positivity. Let's go to Howard County. Now, once again, the date on this is October 1st. This is yesterday, okay? Positivity in Howard County, 3.16%. Eligible population fully vaccinated, 86.9%. Now, I decided to look at another county in rural Maryland, and we know this has been a political football, so I'm just going to show this. You can draw your own conclusions. This is Washington County, which is Hagerstown. Positivity, 9.96%. Eligible population fully vaccinated, 58.6%. I'm not drawing any conclusions. I'm just saying these are the facts, as far as data is concerned, present in our community. And I think, when you talk about risks and benefits, we have to think about it on those terms and think about not just ourselves, but our family and those who are around us. There's one other thing that I wanted to point out, and that is, this actually is a slide that was made in April, a while back, and it's a little bit different now, but this slide shows that there is, as was mentioned earlier by, I believe, Dr. Lawson, there are racial disparities with regards to COVID. And this slide shows that disparities, if you look at the orange line, that is African-American population, the gray line is Hispanic population, and the blue line is Caucasians. And it shows that at that point in time, in all age groups, we were at higher risk. So once again, this is something that's very important, and we need to be very thoughtful about prevention and figuring out what can we do to protect ourselves and those around us.
One of the unfortunate things is that we have a lot of data, but for a lot of people, data really doesn't seem to make a difference in their decision making. That's something that we need to pray about, because it is, as you've shown, our particular community, the African American community, is especially vulnerable to this virus, and yet even in places like Florida, Mississippi, where the infected rate, the death rate is extremely high, we still have a high percentage of African Americans, and many of them quite intelligent people, who refuse to be vaccinated. I just want to again thank all of you for the excellent information that you've shared from your expertise and knowledge. Are there other comments, even questions for the panelists that you might have? I guess you're all talked out. Go ahead, Wendell.
Yes, I can make one statement, because as I indicated initially, I was so pleased that you had the pediatricians here to give their expertise and their recommendations, as well as the OBGYN recommendation, because those are areas of controversy. But my big concern right now, when it comes to prevention, has to do with recognition. If we look at the data again, the masking was even more effective than the vaccinations came in to be, although it had to be assiduous, compliant masking. Sometimes now, when we have been vaccinated, we feel, well, since I'm vaccinated, maybe I'm risk-free and I don't need to wear that mask. I just want to point out that we have the population of children under age 12 who have not been vaccinated. Children have not been vaccinated under the age of 12. The vaccines are not approved for them as yet. And so if we who have been vaccinated can spread the virus, as I've indicated, the data shows that we can harbor and we can spread the virus, even though we don't get sick because we've been vaccinated, we certainly don't want to spread the virus to the children. So the wearing of masks for people who are vaccinated is not for themselves. It's for their brothers. I am my brother's keeper. It's for the children. Wear the mask when you're in an enclosed space so that you don't infect the children. That's extremely important. One other thing, it was pointed out, Dr. McIver, I think, pointed out that the distancing has been decreased in the schools. And there's a reason for that. we actually recognized that even 6 feet was not far enough away. We recognized that people in choir rehearsal with members of the choir practicing who were 18 to 20 feet away became infected from someone in the choir who was sitting back in the corner. So the virus can go much further. The particle size of the COVID virus is the same as the particle size of cigarette smoke. So you would understand how far cigarette smoke can disperse. If someone came into a room we were in, it wouldn't take long for the cigarette smoke to go everywhere, not just 3 feet or 6 feet. The decrease from 6 feet to 3 feet in the schools is because they didn't have enough space in the schools to distance everyone 6 feet. So they had to decrease it because sending children to school was important because the parents have to go to work. If the children can't go to school, they have to get babysitters or the parents have to stay home. So it affects the economy. So don't let those sort of nuances prevent you from recognizing how important distancing, wearing of masks, and hygiene are in this situation.
So I'm going to I want to throw something out to anyone on the panel because it hit me as we were talking, and we really haven't discussed it much at all, and that's the issue of testing. You know, being tested to see if in fact you have been exposed to the virus. What type of test? How frequent you should get the test? Anyone want to comment on that? And even where you can be tested?
Yeah, if I could start with this. I'm going to read this again. This is from the CRISP as well as the Department of Health. And I'll just read the first paragraph. It says, under new statewide testing strategies and with greater availability of tests, clinicians are no longer limited to testing symptomatic high-risk patients. We encourage that you additionally test patients who are asymptomatic and may have directly or indirectly come into contact with a person known or suspected of carrying the COVID-19 virus. This strategy will help identify additional asymptomatic carriers in order to contain the spread of the virus. And it is basically recommending that anybody who is at risk, if you have a job, for example, a healthcare worker, for example, or someone who works in a restaurant, and you're exposed to people, it's encouraging people to be tested, and not just once, recurrently. As if you develop symptoms or you are concerned that you're exposed to someone or you just want to check. That's what the recommendation is.
So you can't. I'm in a hospital. I can't be tested every day, can I? I mean, how often? I don't have the answer to this. How often should one be tested, or does it really depend on the exposure in high risk environments? And what is a high risk environment?
Dr. Watkins, if you don't mind, I would love to kind of chime in on this a little bit.
I actually started to call on you.
That's fine if you call on me. It's completely fine. So a couple of things about the testing, and to answer your question directly, it depends. It depends on your exposure. It depends on where you've been. It depends on where you're going. So if you're a person who has been home a lot, you're not really exposed, just to get a COVID testing, just to have it, may not be the best way to use the resources of those tests. However, if you're actually traveling quite a bit, if you're going to different areas of the country or even different counties, even whether you're asymptomatic, you have symptoms or you don't, then testing is completely fine. What we're seeing is when you're coming into hospitals, a lot of patients are tested. I know they're testing a lot in the ED, especially when we're being admitted. Pregnant patients are being tested when they're going into labor, because you have to remember that they could be asymptomatic, but there are people that are caring for them around them. So you just kind of want to stop the spread. But one thing I just want to add, and this wasn't the question that you asked, but it is a question that I'm asked a lot, And, I think that as providers and those who are aware of the different type of tests, we need to continue to educate people what test is the best test to give. All COVID tests are not created equal. And one of the most dangerous things right now in 2021 and maybe even 2022, as we go into the year, the most dangerous thing right now is a false negative test. Is for someone who thinks they're negative, but they don't have symptoms and they're actually positive for COVID. I'm going to give you a quick example, if you don't mind. I just had, I just talked to a person who called me, and they had a friend that went out of the country. They had to get tested right before they got on the plane. It came back positive. They went someplace else because they just assumed it was not accurate, and got another test, and it was also positive. So what they did is, instead of getting on the plane, they drove across the border because the border did not require a test. And they went and did one of those real quick rapid tests, and they were like, oh, it's negative, I'm fine. And they went to work, only for them to have a colleague about a week later that got severely ill. So what I would encourage people to do is, first of all, find out what test that you're being given. Some people think that just because the results come back, that rapid test is the same as a PCR versus the antigen. Find out which one you're given, because they're very specific tests that you would give someone who has symptoms versus someone who's asymptomatic. They were concerned about exposure. They're very different tests. And I don't want to get into the too much nitty gritty about that, but I do want people to be aware that just because you had a COVID test doesn't mean that that was the best test for you to have at that time. So make sure you find out which one you had.
And the availability of testing is quite is quite I don't know what word I want to use, but they're quite available, and there are a number of hospitals, drugstores. I don't know if Giant is still doing them, but also community centers. And now that you can actually get the rapid test and the PCR test done, and the results back the same day. So, I would encourage people to be tested and utilize that. Dr. Wesley.
I would add urgent care centers and also testing centers. A lot of communities have testing centers that they create drive-through testing centers that we could find where they are online. What we want to try and do is encourage people not to go to the emergency room unless they absolutely have to, because then you're going to have a long wait, and it's kind of people will get discouraged, and we don't want that to happen.
And plus, that's more of a high risk environment. So you go there negative and leave positive. Well, I just want to again thank all of you for your generosity with your time and helping to educate our church and the public on this very important topic. It's still here. And if things don't change, it's going to be here for a long period of time. And so I would suggest that we need to do everything in our power to decrease the likelihood of getting infected, and also to just do things to boost your immune system, and in general rely on the data, the quality data, and not go down these rabbit holes which are leading to death. I was talking to someone today, and they were saying, when you give bad information and someone listens to you and get sick and die, what do we call that? So it's really a dangerous thing, and I'm not for just getting vaccinated just for the sake of being vaccinated. But the virus kills, the vaccine doesn't. That's been my philosophy, and I think that it is something that makes, at least to me, it makes a lot of sense. Any final comments from anyone before we close? We want to let you know that this has been recorded, and that you can get access through the Brinklow website and possibly even the Facebook. If not, once again, I want to thank the Brinklow Church, the communication department, and the Department of Special Events for the opportunity to present this information to the community. I believe it's very valuable information, and we've had such illustrious people to present it. If nothing else, goodbye.